Dr. Julie, I can't believe that the third leading cause of death are medical errors. But the truth is, I read that statistic years ago, and I thought to myself, how is it that no one's talking about it? But you've been on this journey for quite a while. So take us into what got you focused. How did you learn the stat, and how did you shift your career as a nurse into educating and teaching and wanting to make a change to these horrifying statistics?
Yeah, I was already a nurse for 30 years when I entered nursing education. So I'd worked at the bedside, taking care of patients in ICU and in the trauma center. I worked on the helicopter for 10 years. And when I started teaching, I needed to get my master's degree because I only had my bachelor's, and I had to pick a thesis, and I picked patient safety because it kept coming up in what I was teaching students. And when I would dig and find case studies, I was shocked. How was I a nurse for 30 years and I never knew this? We never talk about it in our meetings. Hey, we had a patient fall, or, somebody died that wasn't expected, but it was always kind of thought of as a rare occurrence. And when I started really researching, I was, like I said, just shocked. So that began the journey of, well, people need to know about this because you're right, it's been going on for so many years. In fact, the first article I could find in the Journal of American Medical Association was 1955 that said the most common thing that happens to patients in the hospital is harm. And for decades, we haven't made any inroads. In fact, in 1999, the Institute of Medicine came out with To Err is Human, and they estimated the deaths to be 98,000 a year. And then in 2013, when they did retrospective chart reviews where they could actually go into medical records and say, whoa, no, this happened, the number of patients dying are more like 250,000. Some estimate up to 400,000. So crazy, isn't it?
It's honestly, it is crazy. So, just for the education for my audience, it's an all women audience. Tell us number one killer and number two. So just to get put it into perspective, because I think we're aware of, we've heard those other ones, but just to explain
Heart
it to us.
disease.
Yes,
Yep.
is
Heart
number
disease is
one.
number one, and then
Yep.
cancer,
And then
and then
cancer.
medical error. Hmm.
Unbelievable. Now, what's also curious to me, and we were talking just briefly before the we started recording, I had read those stats a few years ago, and I remember thinking, why is there not more education? Why is there not more information? Why isn't anyone sounding the alarm about this? But I feel like now if you Google it, it's before it was very clear. It would literally say third cause of death in the United States is medical error. And now it's like a little blurry. I think they're like trying to walk that back or something. Am I imagining this?
No, you're right. And I think understanding the perspective of we don't want to scare people, meaning,
Yeah.
we don't want them not to come and get health care. But to me, that's the wrong approach. It is, why don't we build that bridge? Why don't we find solutions? Why don't we look at systems errors that allow humans to make mistakes that harm people? That's where we need to look at this. But unfortunately, there's not transparency in healthcare mistakes. In fact, I read an article that said 80% of lawsuits that a hospital settles with the family, they make them sign an NDA. So it's like sweep it under the rug again. We need to learn from mistakes that other people are making so we don't make them ourselves. But yet, the hospitals know it damages their brand, it damages their reputation. It's starting to impact reimbursements because it's serious.
Yeah, it's very serious. And I just want to say, so I have so much respect and so much gratitude for anyone who works in the healthcare industry. It's like a thankless environment from what I can see. These people are burnt out. The suicide rates of, I don't know if it's specifically female surgeons or female doctors, is like higher than like the national average, as it compares to other women
Yeah.
in general. You're probably aware of this. And so like it just seems to me that maybe it's just been broken for a while. And so I think people go in wanting to do the best thing, but trying to cover it up doesn't benefit anyone, like you said.
Right.
I'm going to read something just so people have some context too, because I Googled it again just to see what would come up. So, in the National Library of Medicine, this was from February 12th, 2024. NIH, it says medical errors have more recently been recognized as a serious public health problem, reported as the third leading cause of death in the United States. One study reported that approximately 400,000 hospitalized patients experience some preventable harm each year, while another estimated more than over 200,000 patient deaths annually were due to preventable medical errors. So, based on the research you've done over the last 15 years, is there any information you can give us about what you see as maybe, some of the major contributors to these really startling,
Scary.
scary
Yeah.
statistics? Yeah,
Yes. And when you look at it and you look at the categories, because I mean, healthcare errors is a pretty broad topic, right? Or a pretty
yeah,
broad category.
yeah.
But when we look at medication errors, nurses are taught in school the five rights, meaning do you have the right patient? Do you have the right drug? Do you have the right route? Do you have the safety measures? But you're right. It's a crazy environment out there, way worse than when I was at the bedside, and people are scrambling to keep up with doing just the priorities, not even. And so they'll cut corners and just say, "Hey, Mr. Jones, here's your, Percocet or something," and it may not be because he's confused. It might not be Mr. Jones or whatever. And there's those kinds of mistakes, but then there's ones that cause the actual harm. For instance, probably everybody's heard that was in the news a couple years ago, the nurse at Vanderbilt that gave the paralyzing medication instead of the sedative
I remember
medication.
that. And the bottles
Yeah.
looked identical, right? It was something that could have been, right? The actual bottles look identical.
Yeah, and so it's that type of thing that is totally preventable. In fact, because an anonymous tip came in, they did a full investigation. Prior to that, they settled with the family, they fired the nurse, and they put on the death certificate natural causes.
Oh.
So that's why I think when we say it's the third leading cause of death, it potentially could be higher than that because of things like that.
Right. This is just what's been reported. That's actually a
Yep.
very fair assumption, I think. Oh, wow. That's unbelievable. Right. I had interviewed at one point an anesthesiologist, and she's so lovely. And she was talking about their safety protocols that they have are very similar to the airlines, where you really have to go through a very rigorous, like, and we were talking about what the advent of AI might do to all of that. And it seems like maybe in certain areas, although I'm sure there's still errors there too, because people are human and maybe sleep deprived or maybe overworked and or whatever, or they're having their own personal challenges and going in and trying to care for others. Like it's a like I said, that's why I have so much respect for the people in these professions. But you had said in your TEDx talk, you say that 70% of the problems stem from a communication breakdown. And I think this made sense to me, but say more about why that is. What does that look like in an actual hospital setting and you've got someone you love,
Yeah.
that you need to advocate for?
Yes. So it can be between healthcare providers themselves,
Oh,
or the communication breakdown can be between patients and the families. So let's start with the healthcare providers themselves. One of the stories in my book talks about a man who went through surgery for a brain tumor, but they said after surgery to him and his wife, it looked benign. Well, the pathology report did not come back benign, but it was misfiled and nobody communicated. So that's a piece. And 6 months later, he's got, headaches returning, and now the tumor is the size of the surgeon's fist, and he did not survive. That is a medical error because the pathology report got misplaced.
mm.
Or another story in my book is a woman who had a boating accident, was critically injured, went through a long rehab in the ICU to be able to get ready to go home. And because she'd had a trach for so long, they did a barium swallow study. Well, in that barium swallow study, it showed that she had a tear in her trachea where the barium actually went into her lungs.
Oh no.
So it wasn't reported because she could have been whisked right into OR and fixed that tear, but nobody reported it. Again, a gap in communication, and she respiratory arrested and died.
Oh,
So it's those kinds of things that are a part of the communication breakdown, but it's multifactorial. And I'll go to the patient side for just a minute. One of the things that I advocate for is speaking up for your loved one. You know them better than anyone. And if you say, hey, my mom isn't acting quite right, that is a communication piece that the healthcare team needs to listen, because you know them better than anyone. And even though you can't put your finger on it, they can do a further investigation, say, oh, her blood sugar's off, or her blood pressure's too low, or her oxygen's too low, and really investigate and prevent harm.
a- absolutely. I mean, I want to make sure. So, this is for the purposes of education and then also empowerment, because I think what we're talking about does sound so, it's so sad and it is so
Yeah.
scary. And also, that's why you're here, Dr. Julie, because this is what you've dedicated your life to for the last 15 years, is to help people understand what is actually within their control. Before we go to that, but let's stay on the. So there's two things I want to say to what you said. One is medicine is so siloed. So you've got your general practitioner, they send you off to whatever rheumatologist, and then then there's a neurologist, and everyone's working in silos. And you're right, it could be very easy. There could be a gap in critical knowledge that could cause something. That actually makes so much sense based on how it's structured. I don't know if AI will change some of this stuff. I have no
Mhm.
idea. I'm not a huge fan of AI, if I'm being totally honest, but I think in the healthcare setting, there may possibly be a huge amount of benefit, and in other areas of life, not as much. But on the patient side, in terms of communication, I would say, I'm going to guess a huge majority of the women who are listening today is going to have, especially if they have children, that gut instinct, or they are advocating for their child, even if they're not even in the hospital. They're trying to get information, and they are like labeled hysterical, anxious, worried well. Like, instead of answering, there's sexism in terms of how women are treated. Would you agree to that? I that's
Absolutely. Absolutely.
by
It is
women doctors and
truth.
male doctors. It's not just men
Yes,
doctors. A lot of times it's the women doctors don't listen more than the male doctors, is my experience.
it is medical gaslighting. It's a
Yes.
real thing
Yeah.
for sure. And you just, again, why we want to educate and empower is to give the strength to speak up, to own your own body, to own your family's outcomes and health. Because, when nurses are taking care of a lot of patients or doctors are taking care of a lot of patients, you unfortunately most of the time become a number, or, Mrs. Jones in 403, or that patient, you're right. But we've got to personalize it. And we as the family members are the ones that feel that, and we've got to bridge and connect that humanity back to the heart, back into healthcare.
Mm, yeah. But how do we do that? Let's be tactical about it. Like, help the women listening learn how to do that, because I find that, once you're labeled, that's tricky. And, I just think that nothing's more stronger than a woman's intuition,
Right.
especially when it comes to someone she loves. And if she's just trying to get them the care that she can see, like you said, if you see someone you love deteriorating or not acting themselves, and you're trying to raise awareness, and they're like, "Oh, you're just overreacting." You, how do you get that communication back on equal grounding so you can be heard? And also, when you're asking questions, the doctor doesn't feel defensive, or the nurse doesn't feel defensive, because now you're asking more questions because the trust doesn't feel like it's there.
Right. I think asking from a point of curiosity and not a tone of accusation, or a tone of, frustration, which in the healthcare setting, there can be many times you're frustrated. And, that's really a vulnerable point. And so when we're vulnerable, our emotions get a little higher. But the
Yes.
other tip that I like to share with people is the three P's: be present. So that means, to me, be present physically when the nurses are doing shift change, or when the doctors come in to visit. If you can time it, find out when they're going to be there, but also be present in your heart. Just come from a place of, hey, we're in this together. We want the best outcomes for my mom, my dad, my son. And I know you, as the healthcare provider, want the best outcomes also. And the second one is be polite. Sometimes it is hard. I've been waiting 6 hours for you, and you're just waiting, especially if, things aren't going so well and it's hard to maintain that sometimes civility. I know a lot of families get really emotional, and even as a nurse, I've had them angry and yelling, and it doesn't really accomplish much. But the
Yeah.
third one is be persistent. And that is when you know something's not right, and you don't have to have nursing knowledge, medical knowledge. When you know something's not right, as you said, your intuition, or you can actually name it. My mom is confused. This, even though she's 80 years old, this is not her. She's not a confused woman. Something's wrong. And if you don't get resolution and if you don't get interventions or somebody to take action, then you need to escalate. So if you're talking to the nurse, go find the charge nurse. If the charge nurse isn't going to help you or you can't find them, you ask for the house supervisor, who's the nurse in charge of the whole hospital, all the patients everywhere. There's also a medical chief of staff. If you've got a doctor who's not answering your questions, or you just feel uncomfortable with, or is not coming back to take care of your son or your husband, you can call the chief of medical staff. And then the last one is the administrator on call for the hospital. Even on nights and weekends, there's a hospital administrator that's on call.
Okay.
You
So
just have to
that's,
keep persisting. Yep.
and you're going to be labeled, even if you're polite and even if you're being present. I mean, you will be labeled, I think, once you escalate. But I think if the risk is looking like they're going to label you versus maybe not saving your family member, I'd err on the side of risking being labeled. Do you agree?
Yeah. Oh, absolutely. Here's the thing. It's
Yeah.
it's difficult to speak up sometimes. This culture that we're in just puts the healthcare team on a pedestal. And yes, I mean, I've done all those years of education myself. And yes, we've learned a lot, but doesn't mean we're infallible. And so working together is the goal. But if you don't speak up, the consequences could be really dire.
Yeah.
You could lose your loved one if you don't speak up.
Yeah, right. This isn't a time to, be
Don't
shy
risk it.
about, don't risk it. Um, it's so easy for people want to Google information, Dr. Google, which obviously is never a good idea, and now probably ChatGPT. So how do we stay informed and ask good questions without going down a rabbit hole and putting the provider on the defensive? Like, is this a point in time where you don't do the research and just allow that? Or if that's the thing, everyone's got so much information at their fingertips, which also probably is really frustrating to providers, understandably.
Yeah, I think there's a smart way to get more information. My students used to Google things all the time, and I'd be like, guys, where you're going is not what I was teaching you about. You're asking about something that's off topic. But I have found actually ChatGPT to be very helpful. And I'll give you an example. Let's just say you're at your husband's bedside and you see the monitor with all the vital signs on there, and you're like, his heart rate's 100. Is that normal? And then
Mm,
look in my book or look online and say, what is a normal heart rate for an adult man? And then you'll see, well, 60 to 100. Okay, that's a pretty big range. And now you're watching and he's kind of restless, or maybe he's a little paler looking than he usually looks. And now his heart rate's 110. And you're like, something isn't quite right here. I would put in ChatGPT and say, what would make my husband's heart rate rise up to 110? And then you'll get answers such as a fever. And then you can find out, does he have a fever? Is he in pain? Is he dehydrated? So it really does inform where you can ask the nurse, hey, is my husband dehydrated? Because he's looking kind of like his tongue is dry. He hasn't had anything to drink in a
mm,
while. And it really can focus you on some intelligent questions. And then that can inform you for the next questions too. If he doesn't have a fever or he does, then you can say, what lab work would I want to look at if I was trying to determine if he's got an infection? Well, white blood cell count. Then you can ask the nurse, hey, what was his white blood cell count this morning? Well, it was 18. And then you look and shake, that's high. What's going
yeah.
on?
And then you're alerting them, and then they become part of your team versus,
Yeah.
right? Then they'd be like, oh,
Yep.
wait, that's data, and data people can work with.
Yes.
Emotions get, depends on the provider you're dealing with. You know what I mean? I just think like
Yeah.
you're right. If you can stay present and grounded and then just focus on data in that situation, that's helpful. You have your cuss words where you can alert. Can you just walk us through briefly the four cuss
Sure.
words? Yeah, this is your acronym for
Yeah.
better communication.
These are used when you're wanting to get someone's attention, just like real cuss words. But the C is concerned. And I'll give you examples here in just a minute. The U is uncomfortable. The first S is scared. And then the second S is this is a safety issue.
Hmm.
So, for example, a safety issue. Hey, I'm really looking at my son's toes. You put the cast on 10 minutes ago in the ER for his broken leg, but I think we have a safety problem here. His toes are blue. That's not normal, right? And just using those words to get the attention, or I'm concerned, like we said earlier, my mother's confused. This isn't like her. Or I'm really uncomfortable with the way my dad's looking right now. There's just something off about him. Or look at his belly. It's all distended. That's not my dad. My dad's really fit and he's got a, flat tummy. I'm uncomfortable with how swollen that is. So that could be from internal bleeding. It could be from a full bladder. It could be for several reasons. But those cuss words should get the medical team, the nurse or the doctor, to really pay attention to what you're saying.
Okay. You've mentioned medications and that horrible story from 2 years ago that most people did hear about the
Yeah.
person dying. And from what I understood, if this is correct, the vials were the same color. So unless she like had looked more carefully, which probably I think there was all supposed to be like somebody else checking too, though, wasn't there like some
Yeah.
so there was
Those
a
are high
big
risk
mistakes. Yeah.
medications. Yep.
Okay, but so what you talk about this, so how do we know which ones can be more dangerous? Like if your family member is being prescribed them, and what can we learn from you about that?
Yeah, I think I have a chapter in my book, High Risk Medications, but let me give you a couple
Yeah, of
examples.
course.
So,
Yes.
pain medications and sedatives. So, the results of those pain medications, and here's the thing, every patient reacts a little bit different. So, whereas 2 milligrams of IV morphine might be great for, the big burly guy in the room, a little frailer, older woman might not need 2 milligrams of morphine. It might drop her blood pressure too low. So,
Mm.
vital signs can be impacted by pain medications as well as sedatives. The other ones that are high risk are any cardiac medications, like for blood pressure or for heart dysrhythmias, or when your heart's not beating effectively. For example, atrial fibrillation is one of them. So there's medications for these and really understanding the mechanism, what they're supposed to do, and then any side effects. So, for example, the atrial fibrillation is when the atria doesn't contract, it's the top part of the heart, doesn't contract effectively, and the blood can pool a little bit. And so the patients are prone to blood clots. And so they put them on a blood thinner. Well, that's usually long term. And so if your husband is put on this blood thinner, there's, pardon me, there's lab work to check to make sure the blood's not too thin or it's thin enough. But there's also what should we watch for? Let's just say you guys went skiing and he hit his head on a tree. That's a big cause for concern because he could have a bleed in his head because of the medication that he's on. And, finding out number one, are these medications necessary? What are they supposed to do? And then how do we manage life on these medications if they're long term?
I like that. Is this necessary?
Yeah. What's it
Because
supposed
some
to
of it's
do?
just protocol and it's just so
Yeah.
standard that, right, by asking that question, it's like, do you really need this? And what's it supposed to do? What are the side effects to look out for that you don't want? And what
Yeah.
is the long-term way to look at that? Okay, I love that. Infections in hospitals. It's not funny. I don't know why I'm laughing, but it makes me, like it's again, it's so stressful. So is this another big medical
It
error?
is.
Such, yeah.
And again, it is so preventable. Nursing students, medical students, anybody in healthcare, 101 you're taught to wash your hands and not just run them underwater for, a few seconds. But in the haste, I'm guessing they don't think it's that big a deal, or I'm going to put gloves on anyway,
Yeah.
but they're still touching things in the room. There's so much harm that occurs from healthcare acquired infections. It extends hospital stays. It's very costly for the medications that have to be given. Patients can get deathly sick. It's called septic shock.
Yeah.
With an infection that goes, from the bladder, from a catheter out into the bloodstream, or a
Yeah.
wound infection. So washing hands is the simplest, and that's probably why you laughed, is because we shouldn't be talking about healthcare acquired infections. It's easy if we follow the policies and the protocols. One hospital study that actually implemented, and they had checking up on each other. Did you wash your hands? And engaging the families. Say, hey, if the doctor walks in or the phlebotomist walks in and they don't wash their hands, you tell them. And it became a team effort, but they decreased their healthcare acquired infections by 92%.
Oh my God. See, this is what's hard though, because my daughter was in the NICU when she was born. She was born premature, and most of the nurses were nice. I had one that was, I think, a sociopath. She was so mean to me and bullied me. And every 8 hours there was a new nurse, and she was there 2 days in a row. And I think she requested it just for like, I don't know. But I
Torture.
walked, yeah, basically, she's like, oh, the worrier. She would call me the worrier. And I'm a first time mom. My baby's in the NICU, and so when the doctor was rounding and was with me, and we walked up, and there was a face cloth covering the entirety of my baby's face. Yes, the entirety of her little newborn little face. And I was like, Cheryl, what's up? Why is there a face cloth covering my daughter's face? And her answer to me was, whoa, whoa, it's the worrier. Relax. She's fine. And the doctor said nothing. And
Oh
in
my
that
gosh.
moment, I knew I was powerless because she was a bully and all the nurses were afraid of her. I watched it. I watched her not respond to the beepers on this baby across the way for 10 minutes. And finally, one of her
Mm.
colleagues was like, go check on that baby. Like, it was horrible. It was horrible.
Wow.
But what was worse was that I did see that the doctor didn't say you don't speak to a mother like that. And also, that isn't protocol. Like, why is there a face cloth cover? That was a fair question.
Right.
And so she also, it was emergency C-section. She told the nurse covering for her when she was running off to lunch. She said, Michelle doesn't like help. Don't help her. She literally said that to her. And I had never opened the incubator for my daughter because when you have a C-section, they seat you and they hand you your baby safely. My daughter, the incubator thing rolled out. She almost smacked on the ground. She probably would have died if I didn't catch her. So I still
Oh my.
have that in my head. And so from that time, and you had to wash your hands. This is coming back to the washing hands every time you went in, which is something I just do culturally. My mom always taught me that. It's just before you eat, I always wash. Like, it's just something I always did. It did heighten my awareness of the importance of that kind of thing, especially in the NICU. So when I would go to doctor's appointments and I'd say to the doctor, do you mind washing your hands before you? Some are great. And they'd be like, of course. And I'd say more often than not, they get really angry. And rights do we have that we're not aware of? You said we need to be able to advocate for ourselves. Is there anything that like the healthcare people know that we don't know in terms of advocacy or,
You know, I think the first thing I would recommend to the audience is check out the hospitals in your area. You go to hospitalsafetygrade.org and you can find out if your hospital is an A, B, C, D, or F. And it's all based on 22 categories of safety.
wow.
If you go to a D or F rated hospital, your chances of harm are 91% higher than if you go to an A hospital.
Will you say that
But
link again? I'm going to put that in the show
mhm,
notes. Hospital.
safetygrade.org.
Okay. I'll link that, ladies.
And you can go in there, you put in the zip code of where you live, you look at all the hospitals in your area, you see, okay, Centera Hospital in my area, maybe they're an A or B, I don't know. And then you look at Fairfax Inova and you can say, okay, you can click on that hospital specifically and look at all those categories and you can see whether they're red, yellow, green in any of those categories. So maybe they do really well in postoperative infections, but they don't do well in postoperative blood clots because those are preventable also. And so it really, again, empowers you. You can say, if you're going in for surgery to your surgeon, I understand blood clots are preventable. I understand also that this hospital doesn't have a very good safety rating in postoperative blood clots. What are you going to do in writing your orders to care for me that I'm not going to get a blood clot after this surgery? And you could say it
Yes.
obviously not in accusatory tone, but just an informed way. I understand blood clots are preventable, and I understand this hospital doesn't have a very good rating on that. I'm sure you guys are working on it, but how are you gonna help me?
I like that. I'm sure you're working on it. Tell us what you've seen in the last 15 years. There's with the advocacy you're
Mm.
doing, like, do you tour? Tell us more about what you're specifically doing day to day.
I'm still running a nursing program for a little while. In my getting out there and giving some talks, I'm producing courses for nurses. I have 23 of them finished on my website. And again, it's to educate the nurses for what they didn't learn in school or they don't remember that really contributes to patient safety. So I did my master's thesis on failure to rescue, which is the nurses, and we just say the nurses because they're at the bedside 12 hours. The doctors
Yeah.
are there 5 minutes, right?
Yes, yes.
And so the patients that are deteriorating or becoming clinically unstable have physiological cues that they show us 6 to 24 hours before an unplanned or unexpected cardiac arrest. So signs like the respiratory rate was 18 and now it's 24. That increase in respiratory rate is the body's compensatory way to say, hey, I need more oxygen to the cells. So something's going on. But if they're missing these cues, next thing you know, the patient's critically unstable, getting transferred to the ICU, or they find them dead.
Oh,
So that's the courses that I'm, put together for nurses. An hour course on neurological changes, an hour course on vital signs. It sounds simple, but understanding the perfusion that happens with blood flow. So that's been fun.
wow. Is there anything on a national level? Like, can you go to call? I mean, what you're doing is so important. So when you're doing these courses, are you training other nurses to then go bring this to their hospitals? Like, is this becoming something? It seems just so critical, Julie.
Yeah, I'm taking it to the hospitals to provide for their nurses so that
Yeah.
it's a asynchronous. They can go online and just take an hour course and, refresh their memory on fluid and hydration. Why is it important to monitor urine output? Lewis, the boy I talk about in my TEDx talk that died, he had no urine output for 24 hours on day 3 of being critical. That again, those signs were missed. His heart rate was going up, his blood pressure was going down. Now he had no urine output. And all of those are the body's signal really screaming, red flags, something's going on here. But unfortunately, they were all missed.
What did he pass of?
He had chest deformity that he was born with. And when he was 15, the doctor said, he's grown into a young man. He's going to have a little bit trouble breathing as he grows into this body with this, little dip in his chest, the caved in part of it. And the surgery went fine, but they gave him a non-steroidal anti-inflammatory medication called Toradol after surgery. It's supposed to be non-addictive and whatever, but there's a side effect of those medications too,
Hmm.
which can cause, even when you take Motrin over the counter, they say take it with food, same classification of medication. Well, and it's also contraindicated in low urine output states. Well,
Oh,
because he was 15, we call this optimism bias. They weren't looking for signs of trouble. And so he kept complaining, of pain. He had chest surgery, so they would give him this Toradol. The next day, he's complaining of abdominal pain. And his mom's like, something's not right. And the nurses just said, oh, it's gas pain. He just needs to get up and walk. Well, the following day, it was even worse. And now his belly's starting to get distended. And the resident said, just give him a suppository. He's probably got a bowel obstruction. I'm
oh
like,
my God.
come on, he hasn't eaten in 3 or 4 days. How would he have a bowel obstruction? Long story short, he had a perforated ulcer that bled into his belly. The ulcer was caused by the NSAID, the pain
Oh my
medication.
God. It's so
Yeah,
sad. And for that parent, and it's interesting because, I'm saying if you're going to go to these hospitals, that NIH thing, the National Library of Medicine that I read in the beginning of this interview, it said, moreover, medical errors have a high cost, estimating the adverse costing the healthcare system $20 billion dollars each year, and others approximately healthcare costs of 35 to 45 billion annually for hospital acquired infections alone. So it seems to me these are businesses. There's a financial incentive to fix these
yeah,
issues. Not to mention, there's no nurse or doctor that wants to cause harm to anyone. The system is broken for them and it's
right,
broken for, it's just the way it is, circulating the nurse and then it's like you said, be there when the nurses change so you can update the latest nurse on what's going on because you might not see that first nurse when you entered ever again.
right.
So it's broken, but I just feel like what you're doing is so, so critical. And I'm so grateful because literally I've not heard anyone talking about this. I'm going to ask you one other question and then I want to, I know we're running, close to the end of the time, but I know that you mentioned sepsis before, and I have a friend who's a ER doctor, and he said the thing I see the most in hospitals is sepsis. Can you talk to, because it seems like that a lot of times when you end up in the hospital, it could occur or be a symptom or like it happen. So can you explain what it is and what to look out for?
Yeah, it starts with an infection. It can have a different kind of source. One of the stories I write about in my book, actually on my TikTok, it's my most viewed reel, but it was a young man, 12 years old, playing basketball in his school on the gym floor,
I heard this
scraped
story
his
and it
arm.
stayed with me
Yep,
because the
yep,
mom was like, this something's wrong. And they
right,
didn't listen to her.
exactly.
Oh,
Yeah.
gee. Okay, tell the story. I didn't mean to interrupt, but I remember
No,
this
it's
story because
good.
it made national news.
Mhm. Yeah. He went home and nobody cleaned his arm because they didn't think it was a big deal. It's just a cut, from
Yeah.
the gym floor. The
Yeah.
next morning, he's really sick, out of 104 temperature. They take him to the pediatrician. And because he had abdominal pain, which I can explain how that happens with sepsis, but, they were kind of thrown off track that something was really wrong. They just said, well, probably take him to the hospital to give him an IV to get him hydrated because, he's got this fever and
Mm,
he doesn't look well, but he probably just has the flu. Well, the lab work that was drawn at the hospital showed a white count that was dangerously high,
mm.
but the lab results were never shared. They were, again, lost in the system. So either the doctor didn't see them or didn't tell the parents, but they sent him home. And the next day, he's even worse. Now the parents bring him back, and the hospital sees he's near death,
Oh, God.
admit him to the ICU for children, the pediatric ICU. And by evening, he's dead because he went into
Oh, God.
multi-organ failure from the sepsis. So yeah, it's so sepsis is the bloodstream infection that starts from another source, whether it's a catheter. A lot of older people get UTIs, urinary tract infections that can cause sepsis. It's interesting with older people too. Their signs and symptoms are usually confusion is the first
Oh.
sign of sepsis, which is different than children or younger adults. But yeah, it kills a lot of people every year, and it usually is because it's rapid, and so it's an overreaction to an infection,
Mm.
and it just causes a cascade of shutting down the organs, the blood flow to the organs, and yeah, just decimates the body really
And
in a pretty fast.
how is it diagnosed? Is it through a blood test? Like, is it a simple blood test or?
So, a regular blood test that would count white blood cells would be the first part of it, just a CBC, complete blood count. And then there is a rapid stress or sepsis test now that they can do within 10 minutes. And people present a little bit different about when they are, and it happens quickly. But there's lactic acid levels that they can check that elevate when someone's in a septic situation. The, pH in the blood changes. But it really is people being on their toes and recognizing it early.
And then antibiotics, I imagine, if it's
Yeah.
infection,
Yes.
is what would
Hmm.
treat it. So it seems like it would be, this seems like something that would be fair to ask if you suspected it, right? In the hospital, just
Yes.
say, do you mind just
Yeah.
ruling out sepsis? Is that fair to say?
So all the signs would be rapid heart rate, 110, 120, an elevated temperature, but it also in later phases of sepsis can go low.
Mm.
So an abnormal temperature, we'll just call it, and the blood pressure will start falling because
Mm.
the perfusion is really going to the main vital organs. And so the hands and feet can get cold. The skin can look mottled. It's kind of white with purple
Oh, yeah.
splotches on it or whatever.
Yeah. Yeah.
But and following the blood work, and people get confused because again, the blood flow is not going to the brain as usual, it's going to the heart. And then urine output drops because the kidneys aren't getting perfused. So those are all the signs that something is
Oh,
radically wrong and
yeah.
needs immediate attention.
Yeah, and thank you for mentioning how it shows up for older people because you mentioned that earlier. You could say, "My mom's looking confused. She may be 80, but she's not normally like this. There's something
Yeah,
else going on here." You've been incredible. Like I think this is such an important conversation, and people need to pick up the book. But is there anything I didn't ask because we do want the women to feel empowered, not worried. Now, I don't want people, I think as it is, people are already worried, to be honest. Anytime you have to go in for surgery, it's scary anyway, or
right.
need to go to the hospital. It's the last place anyone wants to be. But anything you want to make sure the women take away from this conversation, Julie?
Yes, thank you for that question because I think it's really an important one. The more that you can prepare for the inevitable of you or a family member, because one of us will be in the hospital someday. So learn, be curious. If you're taking medications, find out about those. Find the hospital, like I said, that's the
Yes.
safest in your area.
Yes.
Also, make sure your relationship with your provider is one of respect, that you feel like you can ask questions and get answers. That's key, but really treating this as just like you would exercise or eating right. It's what do I need to know about my body, my husband's medications, my mother's, history of health, and really just working together to have those conversations of how can we keep our family safe. And when you do have to go into the healthcare system, just be as prepared as you can with understanding and knowing that the more knowledge you have, the less vulnerable you are, and the better of a team member, a healthcare team member that you can be in contributing to the safety.
Absolutely. Thank you for the work you're doing. Ladies, this conversation literally could save somebody's lives. So please share it with all your friends, your entire family. The more educated we are, the better communicators we will become, which will just have a better, time if you have to go to the hospital and be able to advocate in a respectful way, but that also takes into consideration your gut and what you know your people best. So trust that and work with these amazing people who do work in this system. Like I said, I have the utmost respect. I mean, for you, for over 45 years as a nurse, like thank you, especially, after going through COVID and everything. I think hopefully people have more of an appreciation for just how committed healthcare providers are to it, but it's just the system's broken. In my opinion, it's
Yep,
broken.
it
And
is.
so we're working within a broken system. So you have to do the best you can. If somebody wants to pick up your book or follow you online, where should I direct them?
My book is on Amazon, Surviving Your Hospital Stay, with my name. And then my socials and my website are all drjuliesiemers.com.
Perfect. And ladies, as you know, on your podcast player, all those links will be easily accessible. So you can just go right to the podcast player for this episode or head over to thegoodlifecoach.com. Thank you for being here today. This has been a fascinating conversation. So grateful to you and the work you're doing.
Thank you.